Hi, everyone. Welcome in. I'm going to give it just a few minutes as everyone starts joining and gets your sound hooked up and all of that. So we are so excited to have you here with us. Seeing some great people coming in. So welcome, welcome. You are here for session 8 of AYO Power, which, as a reminder, is a partnership between the Adolescent and Young Adult Oncology Education Working Group and Elephants&tea to bring education to trainees and fellows and anybody in kind of the medical field looking for education around adolescent and young adult oncology care. We have been doing this for several months now and are just so excited about the success of this program. And we are looking forward, as a reminder and a little hint, to be coming back in the fall again for kind of series 2 of Power, and are really looking forward to the next series as well, and are excited to be ending on such a high note here with Dr. John Salsman. So thank you for being here. A few announcements on our end, just a little bit of housekeeping. If you have questions, if you've been to these before, we love the discussion that happens at the end. It is so fruitful and engaging. So please drop questions in the Q&A so that we can kind of facilitate those at the end of the session. We also want to thank AZI as one of our sponsors for supporting AYO Power. And again, just a reminder to sign up for the newsletter if you haven't already, for our emails, in order particularly to get information about the next series as we get started. So thank you, everybody, for being here, and I will pass it to Dr. Mike Roth to introduce our wonderful speaker today.
Great. Thank you so much, Kayla. It's been a real privilege to collaborate and work together on AYO Power. We've been really successful to date, having over 1,000 participants across our session. So big milestone and much more to come. This is really a great way to end our first year with Dr. Salsman. So it's not hard to introduce Dr. Salsman. He is a close friend, collaborator, and really an expert in AYA psychosocial oncology. I will be a little bit formal and give a brief background. John is a professor in the Department of Social Sciences and Health Policy at Wake Forest University School of Medicine. He serves as the Associate Director of Public Health Sciences for Charlotte and the co-leader of the Cancer Prevention and Control Program at the Atrium Health Wake Forest Baptist Comprehensive Cancer Center. On a just sort of breaking it down basis, Dr. Salzman's an international expert in assessment of and intervention for health-related quality of life in AYAs on active treatment and survivors of AYA cancer. And we are truly privileged to have him here. Anytime any question comes up about developmental life stages and how that impacts quality of life, I go to John for all of those questions, and I direct all colleagues to go to him as well. So we're in for a treat here. Please, as a reminder, put questions in the Q&A or the chat. We're going to have an active discussion afterwards. And on that note, I will turn it over to you, Dr. Salsman.
Great. Thanks so much, Mike. That's for the kind and gracious introduction. I really appreciate this invitation. Many of you know, because I've said this before, AYA people are some of my favorite people in the whole wide world. And so I have so much respect and genuine affection for the group that put together this series. And so it really is an honor to be part of this. So as Mike mentioned, I'll be talking about understanding and addressing the psychosocial needs of AYA patients. And I'm really viewing this as a conversation, which is going to be hard to have since you all are muted. So apologies for that, but please be thinking about questions that come up. Mike said that I was an expert, and I guess on paper, yes, I am. And in some respects, but I feel like so many of you all that are in the trenches every day, so many of you all that are patient advocates, really have the knowledge and expertise that we really do learn from each other. So that's how I'm approaching things here. I'd like to start off briefly just with my disclosures. My kids recently introduced me to this feature on Spotify. I listen to Spotify for my podcast. This is not I don't get any money from them, so it's not an endorsement. But I listen to Spotify for my podcast. I also listen to Spotify for my music, and they started doing this thing called a day list, which if you're on Spotify, you may know of that. And it tracks your listening interest, and it comes up with a catchy title or slogan for that. And I thought, how cool is that? So my kids might have like 90s pop dance feel good vibe for the name of their playlist, and one might be grungy country mountain road vibe. So it's these things that are really catchy. And so I thought, well, what's mine? And so literally this came up when I looked at it the other day. So you listen to Overthinking and Acoustic in the afternoon. Here's some depressed sesh, crying, sleepy, weepy. So hey, I guess what better than to have me present on this topic. Literally, when I saw this, I think I laughed for about 2 minutes straight. Um, uh, on a serious note, I do serve on the board of 2 AYA nonprofits, Team Maggie's Dream, which helps keep the dream of parenthood alive for those individuals that want to pursue assisted reproduction and are having difficulty raising funds, affording the cost of that, which we know can be quite expensive. I also serve on the board for True North Treks, which is a nonprofit that helps young adults resolve the disconnectedness in their lives by reconnecting with themselves, others, and nature through week-long wilderness and canoeing trips. If you have patients or interact with any individuals that might benefit from one or both of those, please feel free to check them out. What I'll be talking about today will be briefly giving a background about, and I won't have to talk about this too much because I'm preaching to the choir when we say why we care about AYAs and what is unique about them and uniquely challenging for them that predisposes them to some pretty significant psychosocial needs. Secondly, I'll highlight what a few of those are. I will also talk about social, well, psychological and social, and then what do we do about that? So how can we be thoughtful about screening and assessment? And lastly, I'll say what we know and perhaps what we don't know in the intervention space to where we can move this work forward, and hopefully we'll have ample time for questions at the end. So by way of background, as Mike mentioned, I am trained as a clinical health psychologist, and one of my earliest patients really stood out to me because she was an AYA who's newly diagnosed with cancer. And it came at a time when perhaps unsurprisingly, she had everything going for her. She was engaged, was climbing the rungs of the career track, and this cancer diagnosis happened. And I was meeting with her shortly after her diagnosis as they were just deciding what her treatment plan would be. And she said, John, I don't want any books. I don't want any support groups. I don't want to wear any ribbons. I just want to rip this chapter out of my life and move on. And I think many of us have probably encountered patients like that. For AYAs, this is a time in their life when it's a time of celebration. It's a time of becoming. During the 2010s, there was this group called the Change It Back group. It was part of the Healthcare Rights Initiative that were certifying AYA programs as centers of excellence. And they said, instead of hospital gowns, we want prom gowns. Instead of hospital gowns, we want caps and gowns. Instead of hospital gowns, we want wedding gowns. So AYA should be a time of becoming. It's a time of celebration. But unfortunately, cancer really disrupts that. And it disrupts it in such a way that there's significant ripple effects on their lives. And it's at a time when they are especially vulnerable. And I love how Dr. Jenny Mack framed this in an editorial she wrote in Cancer. I think this was in 2018. And so that's why I have that there. The bold highlightings are my own, but it really highlights kind of this dichotomy between what should be happening for AYAs and what is happening and why that's so profoundly distressing for them. As we know, this can have ripple effects in multiple areas of our lives. If we look at the group across the bottom, we've had fantastic talks from speakers who've already talked about cancer-related infertility. Dr. Bober, I know, talked about sexual function. Sam Watson did a fantastic talk on financial hardship for AYAs. What I'm really going to center on is the mental health and social isolation piece. I really like the framework that Dr. Larissa Nekludoff developed for thinking about quality cancer survivorship care, because it really unpacks the multi-level aspect of what patients with cancer experience. And if you focus on, this is a very busy slide, it's incredibly comprehensive and elegant at the same time. If you focus on the psychosocial effects, this is what I want to target, because she highlighted psychological, financial, employment, and intrapersonal, or sorry, for me, it's both intrapersonal and interpersonal there. So it's this group here. And this is really going to be how I'll organize what I'll be talking about for this talk. So as I mentioned, psychological issues are not unusual for AYAs with cancer. They can be extraordinarily common, including cancer-specific distress, high fear of recurrence. 5-year survival rate for AYAs, as we know, in the aggregate is really good. It's over 85%. But those AYAs will be at increased risk of second primary cancers, increased risk of recurrence. I had one patient that told me one time that he was happy to have survived his cancer, but he feels like a hypochondriac now. And it's so interesting because that feeling, some of that is very adaptive. And at the same time, we know that can border on being maladaptive too. So there's that balance there. There's also a high rate of depression for AYAs and clinical symptoms of anxiety, not just at the time of diagnosis, when it can be at its peak for sure, but it can extend into the post-treatment survivorship stage, as echoed by the comments, as echoed by what we see there for the prevalence for fear of recurrence. And what I'll say about this too is these rates of distress of psychological symptoms are not only greater than peers who are healthy, same age peers who are healthy, but disproportionately greater than pediatric patients with stress, distress, anxiety, depression, and also older adults. So what things tend to predict? There's a number of good population-based and observational studies that have looked at predictors. AYAs that are marginalized or minoritized, racial, ethnic minorities, sexual or gender minorities tend to have poor mental health outcomes. Treatment setting makes a difference. Data suggests that AYAs treated in pediatric settings have better mental health outcomes. Age, we've already talked about for that AYA age range compared to pediatric and older adults with cancer. And time. So the closer to diagnosis, typically distress is higher. Distress starts to abate during the post-treatment survivorship stage, but it doesn't go away completely. And it's still there at a much higher rate than same age peers. So it's still something that's relevant and needs to be addressed. Not reflected here, but other factors are stage of cancer diagnosis. More advanced stage tends to be associated with higher distress, and women tend to report higher distress as well. When we think about distress and psychosocial needs and really social, the social impact, we really have to think about the importance of the zip code, right? Because our zip code is many times more important than our genetic code in our health outcomes. So for social determinants of health, these are the conditions in which people live, learn, work, play, and pray. It's really shaped by the distribution of money, power, and resources in our country and impacted by factors such as institutional bias, discrimination, racism, and more. And these social determinants of health can then impact health-related social needs. So the more immediate needs that individuals have would be things like housing insecurity, food insecurity, lack of reliable transportation that can impact their access to care, access to psychosocial care, as well as uptake of psychosocial care. So in a way, the disparities in health-related social needs are a result of social determinants of health. It's also important to think about the experience of AYAs within the setting of where they receive their treatment. We already talked about the difference between the pediatric or differences in pediatric and adult settings. It's also important to think about the academic settings and community-based settings. Vast majority of AYAs receive care in community-based settings. Where does most psychosocial care, where is the more robust psychosocial services offered? Typically in academic cancer centers, comprehensive cancer centers, NCI designated cancer centers. So access is going to be much greater in those settings, places where AYAs receive care, where they need additional psychosocial care, they often don't have access. What about social impact? We've talked about depression, anxiety, fear of recurrence. I want to step back a little bit from the AYA specific focus and talk about social dynamics overall. Some of you may remember in 2023, our Surgeon General declared an epidemic of loneliness and isolation. This was a ripple effect that came out of the COVID pandemic. And this is a fantastic and deeply worrisome report, honestly. But I love what he said here about the potential for our relationships to be an antidote. Our relationships are a source of healing and well-being hiding in plain sight, one that can help us live healthier, more fulfilled, and more productive lives. I would argue that for AYAs, where a cancer diagnosis can be stigmatizing and can be profoundly isolating, that those relationships are fundamentally important to identify chosen family, to identify those people that have been in their shoes, to identify those connections for them. This fantastic systematic review by Dr. Fox and colleagues was published in Cancer recently. And one of the things that they did was they really looked at what the data show us on social isolation and social connectedness. Interestingly, for social isolation, the prevalence of social isolation among AYAs was not disproportionately greater than older cancer survivors. So social isolation is a problem, it's a challenge across the lifespan for individuals with cancer. So that part was really interesting. And they also found that the prevalence was similar to the non-cancer population as well. What they found for social isolation was that it was related to worse psychological well-being. Social connectedness, in contrast, was often, but not always, related to better psychological well-being. So what about that social determinants of health piece? In this work by Katie Darabaz et al. Looked at population-based, data from the NIH All of Us research program, where they compared measures of neighborhood social environment, shared values, aspects of the neighborhood, built environment such as access to transit, recreational activities. So kind of that interplay between social determinants of health and health-related social needs that I was talking about earlier. What they found, perhaps unsurprisingly, but really important when we think about young adults with cancer, is higher levels of neighborhood social cohesion and neighborhood walkability and bikeability were significantly associated with lower levels of loneliness. So those AYAs that live in cohesive social environments have those neighborhoods that are walkable, that are bikeable, that have built environmental amenities such as green space, grocery stores, public transportation. Those factors can be protective, potentially protective against loneliness among young adult survivors. Now, this was, of course, cross-sectional data, so they point to the need for more longitudinal findings to replicate this, but it's important about our local and our extended environments. So what about assessment? So this is a problem. It's not uncommon. What do we do about it? I'm a big proponent and fan of patient-reported outcomes. There's some measures and things that we can understand from patients that we can do from basic blood draws, from lab tests. There's other things where patients are the only reliable source of data. For anxiety and depression, social isolation, yes, there are behavioral components of that are observable, that are measurable from a clinician or a significant other, and there are affective and cognitive elements where we need to ask patients. This is Jill Feldman, who is a lung cancer survivor, who, side note, will be receiving the AYA Patient Advocate of the Year award. She's a fantastic, it's a well-deserved award. She's a fantastic advocate in this space. She was diagnosed with lung cancer as an AYA. And so this is a slide that she prepared, and it's such a useful visual about thinking about what we see versus what's going on under the surface. So I'm a big fan of the patient-reported outcome measurement information system, PROMIS. I trained with colleagues at Northwestern who are the main architects behind this. I've done research on this work. It's a rigorous measurement science approach. It's not the only approach. There's absolutely other good measures of health-related quality of life. And there's a lot of value in promise for the reasons that I've listed here in the left-hand column. I won't go through all of these things, but this really highlights why promise can be a solution for better understanding health-related quality of life, which is inclusive of psychosocial concerns, not limited, but inclusive of psychosocial concerns. Promise provides meaningful scores. There are computer adaptive tests that can be administered with minimal response burden that doesn't sacrifice any measurement precision. The scores have meaning. They can be linked to potential action points as well, and they're translated into Spanish and other languages as well. Dr. Roth and Dr. Susan Parsons led a National Clinical Trials AYA PRO working group that helped refine or standardize some recommendations for how we might go about doing this. And one of the recommendations that came out of this in this blue box here is we see the Promise AYA Health Status Profile. So there's items in there that assess depression, anxiety, as well as emotional support, with recommendation of repeated measures assessment at study entry when we know that distress is routinely high, as well as interim disease evaluation. We hear a lot from AYAs, from patients with cancer across the lifespan about scanxiety, which is a very real thing. When they're coming back in for scans to see if treatment is working, that's an understandable time of high distress. Also, end of treatment is a time when many patients want to be celebrating, but there's some understandable anticipatory anxiety, as well as what's the next step. I'm leaving the safety net. What's that going to be like? And then regular intervals in the post-treatment phase. I mentioned the benefits of computer adaptive tests. The way computer adaptive tests is with each subsequent item, you get an item that gives you more measurement precision. So you can ask about more measurement domains. In this case, you can ask about anxiety, depression, emotional support, for example, in fewer items. So it's less burden on your patients, but you still get really good measurement precision. What do the scores mean? Promise uses a metric based on T-scores. So a mean is 50, a standard deviation of 10. So 2 standard deviations is really a good rule of thumb for thinking about when elevations might be clinically significant. The way Promise is scored is higher scores reflect more of the underlying construct. So for anxiety and depression, higher scores would be bad, for example. For emotional support, in contrast, higher scores would be good. But that T-score of 70 would be a good rule of thumb for thinking about when it might want to trigger a referral to a member of your team to follow up and ask more in-depth questions or conduct a clinical interview with a participant. All right, what about interventions? The National Comprehensive Cancer Network has developed AYA-specific guidelines to address a whole host of issues that AYAs encounter. This is not an exhaustive list of their recommendations for psychological needs or social needs in AYAs. What I've tried to highlight are some specific recommendations that align with some of the issues that I've mentioned here. And I've got the DOI reference below there if you want to look these up. But quickly running through these, the goal in order to address psychological needs are to address potential concerns regarding treatment, assist with coping mechanisms. Here, we know that AYAs, they haven't had a lifetime of developing coping skills. And many times their social support networks can be quite limited. So helping them think through coping mechanisms to reduce any of that anxiety is key. Screening for depression, anxiety, suicidal ideation behavior, self-injurious behavior. Thinking about ways to help alleviate distress. And also, I mentioned this earlier, marginalized and minoritized AYAs are at greater risk. So what can we do for those individuals who might have additional concerns that make their experience of being an AYA with cancer even more challenging? What about for social needs? It really is focused on interpersonal within the healthcare team. So thinking about collaborating and communicating better between the patients, parents, caregivers, children, spouse, partners, etc. Also thinking about AYA-specific activities and support groups to connect AYAs to, as well as the relevance of peer support and social networking opportunities. It's really important for AYAs when they feel so disconnected from their peers to try to encourage that level of engagement. as well. Dr. Megan McGrady and colleagues did a fantastic review paper published in JCO recently talking about psychological outcomes, doing a high-level, big-picture take on what the research data shows us. They looked at 4 specific psychological outcomes: emotional health, social functioning, cancer-related cognitive impairment, and health behaviors. For emotional health, they said the intervention data so far focuses primarily on feasibility, acceptability, and safety. There's an increasing emphasis on mHealth, eHealth, so digital health approaches, but there's a relative lack of efficacious interventions so far. So there's a clear need to move that data along the interventional continuum. For social health, similar sort of thing. Primary focus has been on interventions, increasing social support, which is obviously a great thing, and sometimes in combination with another intervention target. But those data have been primarily feasibility, acceptability, these small pilot studies that are an important part of the process, but we need to be thinking about advancing the next step. What about interventions that are community-based? And these are a few of the phenomenal, this is not an exhaustive list, but these are a few of the phenomenal nonprofits in the AYA space that have resources to provide those connections to help AYAs buffer that experience of depression, anxiety, that help them to address some of the disconnectedness they may feel. We absolutely need to think about community engagement. We actually need to think about bi-directional engagement in particular. And last but not least, when we think about addressing distress, maladaption, it's not just focusing on what's going wrong with a patient. How can we think about what's going right? And how can we think about leveraging strengths? This work that I did with Dr. Abby Rosenberg, there's also a companion paper to this focused on health equity and resilience that would be shameless plug, that would be worth your time to check out. But when we think about resilience, it's the process of harnessing resources needed to sustain well-being in the face of stress or adversity. For us, it's really thinking about what works for whom under what conditions. This blue box talks about some of the things we've mentioned already, these social determinants of health, health-related social needs. What's the context through which AYAs are already functioning? The blue series of boxes are, you can think about almost chronologically, the event of cancer, how AYAs think about what that means, how they interpret what that means to them, their coping resources or lack thereof, as well as what comes out of that, how they behave, how they think, feel, and act. And lastly, the resources in the broader context. They're community-based, interpersonal resources. How do they leverage those? How does that impact this whole process? Our recommendation, based on reviewing the data to date, seems to suggest that providing a la carte options, so multi-component interventions. We know that one size does not fit all, that what works for one AYA will not work for all AYAs. So providing multiple options that provide an array of choices may be the best approach at maximizing resilience. And when we talk about maximizing resilience, there's often a benefit of reduced depression, reduced anxiety, increased hope as a result of that. So in closing, just a few things I want to highlight. One, center and normalize the patient experience. Brad Zebrak and colleagues wrote a paper from the AYA Hope study a few years ago called Cancer Sucks in other musings. This is exactly, it's 100% true. This is hard. It's especially hard for an AYA. They're going to be experiencing this in such a way that can be quite debilitating for them. Don't invalidate that, normalize that, and normalize that it's okay to not be okay. 2, ask the right questions. I do that in quotes specifically because sometimes it's hard to figure that out, but there's really good, well-designed measures. I mentioned PROMISE, the European group EORTC QLQ-C30 has AYA measures they've developed as well. There's other AYA measures that are really good too, but be thoughtful about that. And when you ask patients don't mind answering questions. They want to know the information's being used. They want to know how and why it's being used. So be thoughtful about that too. Close the loop with them. Leverage the medical team community strengths. So both the healthcare provider team as well as the broader community, AYAs have their biological family and they often have a very robust deep chosen family. So be thoughtful about how we leverage those individuals in providing that support and helping address some of those concerns. And again, another seamless self-plug as a researcher, partner with us to advance supportive care studies. As Dr. McGrady et al. Mentioned, there's some great research, but we need to keep moving the needle to think about efficacy and effectiveness. Okay, I started by talking about a patient who wanted to rip a chapter out of her life because of how hard and challenging this was. Many of you know Allison Rosen, who's an amazing patient advocate, colorectal cancer survivor. Back in the fall, the ASCO Post published an article that described her experience of having colorectal cancer at 32. And the title talked about how it changed the trajectory of her life. And the subtitle was, "The life I envisioned before cancer is very different from the life I'm now living, but it's a small price to pay for being alive." I won't read the whole quote for you there. You can see that there, and there's the link to the article. But she's such a fantastic example of someone who says, yes, I wouldn't wish this on my own worst enemy. And there's ways that I've rewritten this chapter in my life. And I would suggest, as individuals here on this call, as providers, as advocates, as researchers, that we're here because we care about helping AYAs live richer and fuller lives. We care about helping AYAs write new chapters. So I'm happy to take any questions. There's my contact information. If I don't get to your questions or if we run out of time, please feel free to reach out to me.
Wow, that's outstanding, John. Thank you for that. I see some applause coming in, floating up the right side of my screen. There is a lot to sort of address and cover there. And unfortunately, every time I see you speak, I have more questions, but I want to make sure others have the opportunity to ask theirs first. So some of the questions that have come in through the Q&A. The first one is about the role of advocacy organizations and what role they can play in research and partnering with psychosocial researchers like yourself to further improve outcomes and understand what are the true needs of our AYAs.
Yeah, it's such a good question, and it's an area that I've admitted. So I was trained as a clinical health psychologist, and our focus as a health psychologist is, as a clinical psychologist, is on the individual person. So for those social ecological models that think about the concentric circles around in the larger, broader context that AYAs fit in, that was not a model I was trained in. So I often just focused on that individual. As a result, I missed some important pieces. I think this is an area that's growing. It's an area that we 100% need to be more thoughtful and engaging. We have models through community-based participatory research that do this really well. Many NCI designated and comprehensive cancer centers will have a community outreach and engagement group that's really focused on leveraging the community in a very thoughtful, intentional way throughout all aspects of the process. And that's an area in my research where I'm shifting. I'm embarrassed to say it took me this long to come to this point, but it's an area where I'm shifting. So I think, how do we do this? It's fostering these conversations from researchers to the community nonprofits. It's taking an advantage of just getting to meet and know them, understanding who they are, planting seeds. It won't translate into research right away, but it plants seeds about future opportunities. And it's the community groups that have a better sense, have a really good sense on the pulse of what matters to patients. As researchers, we want to do work that matters. We want to do work that's impactful for patients. Our community partners know what matters. So that bi-directional exchange is essential.
Yeah, I appreciate that. I love that you brought Allison Rosen's quote and her advocacy work into your talk as well. It's a great example of how our advocates really do impact change in our community. The next question is about addressing AYA psychological or psychosocial concerns such as anxiety or dealing with trauma that relate specifically to interacting with the healthcare system.
Yeah, so one of the things that I think is good and bad about me is I have very little filter, so I kind of say what I think. This is being recorded, so I have to pause and filter more. But AYAs will often say they don't know what they don't know, which is, as my teens would say, valid. And where I've seen this work well is Teen Cancer America, among other organizations, have done really good work about helping cancer centers develop capacity for better AYA care. The type of question that you're raising to me is helping bridge that gap of not knowing what they know, filling that knowledge gap to better understand what resources there are, better understand the sequence of things. Teen Cancer America has done a good job about helping fund AYA patient navigators, for example. I see that as a clear role in addressing some of those some of those knowledge deficits. Then if those because anxiety is driven primarily by uncertainty and lack of knowledge. So sometimes anxiety can reduce simply through having a clear idea of what happens next, having a clear idea of who to talk to with questions and concerns. So that navigator can be an enormously helpful first step. And then after those knowledge deficits have been addressed, if there's still mental health deficits that seem above and beyond kind of what would be expected to be some of those routine sorts of things, then we might want to think about involving more psychosocial care, an oncology social worker, a psychologist.
Yeah, I really appreciate the need to better resource our care delivery centers, our places where our AYAs receive their cancer care, to focus on the needs of AYAs. It's a question I have for you in a few minutes as well, is how do we do better in some of those community sites? But I really love this question in the Q&A of stating that often as time moves forward, many of our younger patients and survivors get less and less social, and they get outside less often. How do you recommend to help convince them to get outside or get more social, get past the stigma? And I know that's a really challenging thing that many of our patients face, not just during treatment, not just shortly after treatment, but long-term as well.
Yeah, I don't think I have a good answer for that, because that is 100% really challenging. And I didn't get a chance to work this in when I was talking about interventions, but prehab, exercise, rehabilitation medicine, these are areas that can often be overlooked and are so important for mood management, so important for regulating sleep, so important for improving cognition. So we absolutely need to think about how we create space for that to be a priority. I think the data show that a third, or maybe it's only a third of AYA survivors are meeting recommended ACS guidelines for engagement in physical activity. So as we know, these are AYAs that are in their physical prime. So there's opportunity, there's clear benefit with few side effects, if you will, from exercise. So how do we bridge that gap? As a psychologist, some of the opportunities or some of the suggestions would point to motivational interviewing, where you just focus on moving people along based on where they're at. So if they're in this contemplation stage, hopefully they're in a contemplation stage where at a minimum, they're thinking, this could be good for me. I don't know though, do I have time? What are the barriers? And you kind of talk through that and you move them from contemplation to planning, and then you move them from planning to action through, it's like moving them along through simple nudges. That's one strategy. I think another approach which really leverages the social dynamic is the times I've been most engaged in physical activity and the times that I've had peers and others that have been most engaged, especially when you're talking about adopting a new behavior, there's a social norm around it. So how can we leverage, I showed a number of fantastic AYA nonprofits there. I didn't talk about First Descent. I talked about True North Treks a little bit early on, but there's other groups that are focused on physical activity as part of wellness. And so getting AYAs connected to that to help introduce that social norm that could be a facilitating factor and help overcome some of the barriers would be good. So those are, I guess, two general strategies off the top of my head.
Yeah, it's really helpful. It's so interesting. I was in our AYA clinic yesterday. I had a patient who wanted me to provide sort of the doctor's approval to go to First Descent. First Descent's coming up soon. So yeah, appreciate that need or desire to sort of encourage people to get back into the community and further develop or relationships or develop new relationships. It's been a big struggle for a lot of our patients. Question in the chat is research. So where are things going? Where do we need to go? And then probably most importantly is how do we actually make sure the research is impactful and is translated into practice, not just in our manuscripts, but actually in the daily care of our AYAs?
Oh, I feel like that feels like a planted question. I love it. I love it because Mike, I could probably give a whole talk on that because I think about this a lot in a meta way. Again, I will say I don't have really succinct great solutions. But Scott, I wondered if you'd be, sorry, I'm distracted now by the chat. Scott, I wondered if you'd be on the call. So I wanted to make sure I put in a plug for the exercise is medicine piece. So I'm glad you're here. So where's research going? I think about this a lot because I'm at the point in my career where I've checked, again, I've checked a lot of professional boxes off. And it's, for me, it's, all right, how can I be more impactful in my research? And so I think about things through a lens of 3 different areas. When I have research opportunities, I think about, is this opportunity potentially paradigm shifting first? Secondly, I think about, is this opportunity potentially practice changing? Second. And then third, I say, is this opportunity potentially policy relevant? So paradigm shifting, obviously, how do we rethink how we've been doing our work before? And is there a way that we're missing the boat? As academicians, sometimes we get too isolated in ivory towers and we don't look at things from multiple team perspectives. That's why that slide, summary slide where I was talking about leveraging your teams and getting different perspectives, we know diversity improves so many areas of our lives. And so diversity within your teams really improves that. It helps you think about things outside the box. It helps you shift paradigms. Practice changing. How can we leverage interventional and interventional treatment and interventional non-treatment trials throughout the National Clinical Trials Network to better advance the science and better improve outcomes for AYAs? Third, policy relevant. Should speak to your legislators, show up to town halls. Annually, ASCO does an advocacy summit where they basically do a paint by numbers approach. I did it this past year for the first time, and it really demystifies a whole lot of the process about getting involved in advocacy work. But I would encourage, and I know other professional organizations do something similar. So do that. For AYAs, Sam might have talked about this during the last talk, but health insurance, financial toxicity, there's clear policy relevant implications there. Sexual reproductive health, clear policy relevant implications there in the AYA space. Two other comments, and I'll stop about research. Where do I think we need to be going? I think we need to be mindful of, this echoes some of Dr. McGrady's comments in her JCO review. We need to be mindful of e-health and m-health. AYAs are digital natives. We want to be able to deliver high fidelity, scalable interventions that improve reach and access. Leveraging digital health can help us do that. There's still challenges in that space for sure, but that's an approach that we need to have. And how do we make sure that these things are translated into practice? That's where the emerging science of, well, it's really not emerging anymore. I think it's emerging in the AYA space more. Dissemination and implementation research. we need to be really mindful of. That's where engaging clinician partners, those individuals that are in the trenches with the researchers, to think about workflow integration, to think about what's helpful, to think about where the barriers are, how to reduce those barriers, can be really helpful. So those are more meta thoughts on what we can do, but yeah, great question, and it's definitely directions I would love to see us go in the next 10 years.
So I'm glad, John, this is being recorded, because I want to sort of snip out that response and share that as often as I can. I love what you said about making sure what we're doing is impactful and has meaning and really leads to change. I think for many of us in the academic world, sometimes those goals are blurred, and it's really not about publishing papers. It's about developing meaningful interventions to improve the lives of so many. You know, what many on this call do on a daily basis as they care for our AYAs in different capacity. I love the fact that you're mentoring, all on this call as well, and just giving us ideas on how we can sort of make our careers more meaningful, whether it's as an advocate, whether it's as a psychosocial provider, or in another role. I know we're going to run out of time at some point because questions keep coming in, but I do want to make sure we use this time efficiently with you. So we know that all AYA cancers are rare cancers, but what about rare cancers within AYA cancers, and how that could impact psychosocial health, the uncertainty that further exists within these groups of patients who have really rare cancers where we don't maybe know that much about outcomes, prognosis, or how that impacts different short and long-term areas of health.
Yeah, so Mike, just to clarify, so when you say what about, tell me remind me the specific question there.
Yeah, so we know that all cancers in AYA, the AYA age range, are considered rare, but
Right.
there's certain cancers that are even rarer where we just know much less. And when you combine that with it sort of being a young adult and the uncertainty that comes with that, where we just maybe don't have that guidance, or you don't have others you can connect with who've gone through similar experiences, what do we do with that? How do we address that?
Yeah, honestly, I would be really curious how, the organizations that do some of the peer matching, I'd be curious to know how they handle this on a regular basis, and what sort of, when they can't match, for example, on the specific cancer type, what are the other factors that they match on? Now, I will say data from psychological research suggests that distress does not vary as a function of disease type or disease stage among AYAs. So we might argue that while their cancer type and maybe the type of treatments, the particular symptom burden might be relatively unique and different from others, their experience of anxiety, their experience of depression, their experience of fear of recurrence, that's going to be common. And that's going to be a shared experience. So if we're talking about addressing psychosocial needs, I would probably be more inclined to say, if we can't match on like age, gender, education, partner status, and cancer type, I would try to match on some of those where we do see like developmental characteristics. We see some differences in AYA's experience of distress. So I might think about which of those characteristics are more important to match on, to make sure that the patient can feel seen and heard and validated in their experience, and really get the help that he or she needs.
Appreciate that. I'm finally going to sneak one of my questions in. I'm going to try to challenge you a little bit. So if you were a consultant being brought into a community cancer site who doesn't care for that many AYAs, but has, a reasonable population of AYAs with cancer, and they want to try to improve the psychosocial healthcare for their younger patients with cancer, what would you recommend to them that are sort of feasible ways to address the psychosocial needs of their younger population, which is still the minority of their patients? How would you counsel them?
Yeah, so again, another good question, Mike. We, within the mental health sector, there's a workforce shortage. There's workforce shortages in multiple areas of healthcare, sadly. It's certainly there in the mental health sector as well. When I've thought about similar questions about this, even I've thought about this within the context of resilience research, and when do you want a peer coach versus a self-guided sort of intervention versus when do you want and I think this comes down to a stepped care approach, essentially, where you can, with limited burden on your resources, do some screening to identify the level of distress, and then set some thresholds based on level of distress and potentially a brief clinical interview afterwards about which patients would need additional follow-up by a skilled professional, skilled licensed professional, versus which patients might be experiencing high but normal within the context levels of distress. And maybe those patients would be ones who would benefit from the one-on. Honestly, I think all patients would benefit potentially from the one-on-one or the peer support that's provided through some of these nonprofits. But I think there's a way to think about leverage. This comes back to the community, kind of full circle, comes back to the community question. This is a way where we can really be thoughtful about leveraging community resources in our community partners, because there's a group of patients that could get connected easily and virtually to some of these community activities to address some of their concerns. And then there's a smaller group, hopefully, that have clinically significant levels of psychological issues, perhaps that predate their cancer diagnosis, that might need more structured follow-up care.
That is really insightful. I'm going to ask one quick follow-up of, do you think we can sort of risk stratify patients early? Meaning, do you think at an early stage we can identify who's going to need the sort of the low touch, who's going to need the community-based approach, and then who's going to need more of the one-on-one care?
I like that question. Not that I didn't like your other ones. I'll say yes with some confidence intervals around it, right? There's going to be some noise in the data for sure. I think at a minimum, we would be able to risk stratify based on some of those characteristics, some of those social determinants of health, some of the clinical demographic characteristics that we know already. There's some intrapersonal characteristics and access to resources that I talked about from that resilience slide that we wouldn't necessarily know at baseline that perhaps we could get into with some brief questionnaires. I like the idea, and I think it's possible. And there may be some folks on the call who are already doing something similar. But yeah, it would be a great strategy and a great way to think about optimizing resources.
Yeah, thank you, John. That's really, really helpful. There's one last question, and I'm going to kick it over to Kayla in just a minute to finish up the session. But when starting up support groups for AYAs, what are the best ways to get them to start attending, to continue their participation, especially if there's sort of a slow startup time?
Wow. I'm a parent of 2 teens, and I'm having a hard time figuring out how to motivate them sometimes. Honestly, the first thing that came to my mind was food, but we're talking about a patient population that honestly, some of these support groups are virtual. So not to play the psychologist card here, but I would flip that question back on the AYA advocates to say, hey, what works? So I'm on a research team with Dr. Christabel Chung, and we were talking about recruiting racial and ethnic minority AYAs. And she said one time during the conversation, she said, we're here, y'all are just doing it wrong. And so we need to do a better job of listening to our AYAs in the community and figuring out how to take multiple different approaches, and also to recognize again, 15 to 39, a lot of disease heterogeneity, a lot of developmental heterogeneity. So we've got to be pretty malleable and flexible in our approaches.
Yeah, I love that comment. I could hear Christabel's voice in my head saying
Yeah.
that it's not reaching us. We're not, providing patients what they need. Well, John, this has been great. Since we know each other well, and you're someone I view as such a wonderful psychosocial healthcare provider, psychologist, and you shared with us a little bit of some of your sort of inner mood with your Spotify playlist or mood, whatever you call it. I
Can we
wanted to,
be depressed, Sesh?
well,
My DMs are open. If I do parties like weddings, graduations.
it was concerning. I think this question might be filtered out as well, in addition to that comment you made. But we were having an internal family debate last night, which I'm hoping you can solve for us. The last question that I have, and we will kick it over to Kayla, is that if you had a sore throat, and this is going to seem a little bit random, but this is a true issue in our household. If you had a sore throat and needed a cough drop, there's another name for that cough drop, which starts with an L, and it's spelled LOZ and then goes forward. How would you pronounce that? And it really matters how you answer this.
I would say lozenge. I can't even lozenge.
Okay. Yeah, so that's not the answer that I was looking for, but my family will be happy
This will
with
be the
that.
B-roll, right? Kaylee, we talked about the B-roll of this. Yeah.
So yeah, in all seriousness, John, this has been an incredible session. You have so much insight, and what I really appreciated most was just the passion and the desire to impact change and improve care for so many. So, you are the perfect person to end our first season, our first year of AYAO Power. This has been a fabulous curriculum that we've started. This is only the beginning. I want to thank you, on behalf of AYO Power, our many attendees today, the folks who are going to join and come to our hub online as well. I also want to remind our participants, we're going to start up again at the end of summer, early fall, so more to come. The curriculum is evolving. We're going to have more great speakers, more great topics. And on that note, I'm going to say thank you one more time and then kick it over to you, Kayla.
Thank you. I echo everything, obviously, that Mike has said. John, thank you so much. Behind the scenes, I hope you know we've already signed you up for many more sessions of Power. So we'll keep you in the loop about that.
That's
So
great.
we just appreciate you. And I know someone mentioned in the chat, that we could really feel your passion for this topic and are just so appreciative for sharing with all of us. Lisa has dropped a survey. Speaking of, being impactful and making meaningful progress, that's exactly what Power is about. And so for those of you that are here in attendance, we would love your feedback on the session. Also, stay tuned. We will be doing kind of a full season 1, very brief survey to get some feedback from everybody that has attended 1 or more sessions, just so that we can hear from you what it is that you're looking for and needing, and use that to guide season 2 of Power. So the last thing I will say, to embarrass both Mike and Scott, is a huge thank you to the two of you for coming to Elephants and Tea, for starting this initiative, for being so passionate about the young adult population. We wouldn't be here without the two of you coming to us with this idea, and the education working group. So just a huge thank you to you both, and you have been an absolute pleasure to work with, and that's the only time I will ever say it, even though this is recorded. So speaking of recordings, you can find all of our previous sessions on the Power website as well. So please check out our on-demand information there, and just thank you again for being a part of this, everyone, and enjoy the rest of your week. Thank you so much.
I'm not going to let Kayla close it out there without us saying a huge thank you to Kayla and the rest of the Elephants and Tea team. Really, this could not have happened at all without Kayla and Nick and everybody. So really a huge, huge thank you to you guys for supporting this whole program and everything that you do.
Thank you, Scott.
And for the record, it's lozenge. It's
No.
thank you,
Where are
guys.
you from?
You can cut that when you record it, right?
Have a good week, guys. John, thank you. That was awesome.